This is Unit 4B, basically the cardiac lecture. So can you trace the blood through the heart? Instead of me boringly telling you how the blood goes through the heart, I figured I would play a little song for you. The other option was a Justin Bieber song, but this is a little more my speed. So here you guys go. Alright, so I hope you guys like that again a little bit more than my voice all the time. So that goes through all of these slides. Now we're going to talk about fetal circulation shunts. Three kinds. You've got ductus venosus, foramen ovale, and ductus arteriosus. We're going to talk about them more in depth now. The ductus venosus carries oxygenated blood from the umbilical vein through the fetal liver to the inferior vena cava, and it closes soon after that umbilical cord is clamped, so soon after that baby's born. The foramen ovale is an opening between the right and the left atrium, and oxygenated blood flows from the right atrium to the left atrium. It usually constricts within 3 to 7 days after birth and then closes during the first month of life. Ductus arteriosus is the opening between the aorta and the pulmonary artery. Oxygenated blood flows from the pulmonary artery to the aorta. This usually constricts within 10 to 15 hours after birth and then permanent closure by 10 to 21 days after birth. It can, actually it's not going to close if their oxygen saturations are low, because that oxygenated blood is not going to close it like it would if there's not as much oxygenated blood. So if they have some underlying respiratory issue or something like that, It may not close on its own, and it can reopen if there's an increased oxygen need. So cardiovascular changes from fetal to pulmonary circulation. Obviously, before the baby's born, it is relying on the mom and that placenta, and then once it's born, it's got to rely on its own circulation. So it must shift within a few hours after birth. There's going to be an increased left arterial pressure, which closes the foramen ovale, and then again the higher oxygen levels, which closes the ductus arteriosus. There are quite a few differences between adult and infant cardiac anomalies and anatomy and all of that. Infants are at a greater risk for heart failure than older children, just because older children, their hearts have developed pretty much by then. And infants are at a greater risk for volume and pressure sensitivity. They have a limited heart capacity, and they have a greater metabolic need for high cardiac output. And infants' hearts are basically, they're less developed, they're less organized, they're less compliant, they have a reduced stroke volume, and by 9 years of age, the heart has increased by about 6 times. So like I said earlier, infants are at a greater risk than older children for for heart failure. Congenital heart defects, there are more than 35 known defects, and they begin within the first 8 weeks of fetal development. Survivability is greater than 85%. We've come a long way in cardiac care for pediatrics. And it's classified by a change in blood flow, so either increased pulmonary blood flow, decreased pulmonary blood flow, obstructed systemic blood flow, mixed systemic and pulmonary blood flow. And again, we're going to talk about all of these more in depth, and then they may be cyanotic or acyanotic, which we're going to talk about now. Acyanotic lesions usually see an increase in pulmonary blood flow. You're going to have left to right shunting and obstruction. It's going to manifest during infancy or early childhood. Cyanotic lesions are right to left shunting, and you're going to have decreased pulmonary blood flow. There's going to be a mixing of the lesions, and it's going to need cervical intervention. I did find this cute little drawing online by a UVA student so this can help you when you think about acyanotic and cyanotic. So cyanotic is going to be the 5 T's. The lungs are saying, what about me? Because it's skipping the lungs. It's going from the right to the left. We're not going to go over all of these T's, just so you know, but they do exist. And then acyanotic, VSD, PDA, ASD, AV canal. So that's just a good little drawing to kind of help you remember and help you in your studying. Okay. Oh, shoot, sorry. Back to the beginning. All right, so assessment of the child with a congenital heart disease. You're obviously going to auscultate, see what's going on. Murmurs most of the time already exist in these children. There may be fluid in the lungs. They may be tachypnic. You're going to look and see what they look like. Again, you're going to assess. Are they cyanotic? Do they have pallor? Are they squatting? Do they have edema in the face? Are they tired? Do they have poor weight gain? You're going to do palpitation, and so you're going to see if they have diminished pulses. So you're obviously going to want to check all 4 pulses. Sometimes, depending on the defect, you may have stronger upper extremity pulses and lower extremity pulses. So you really want to palpate and figure out the strength of them. Also look at peripheral edema. So clinical manifestations of increased pulmonary blood flow. You're going to have tachypnea, tachycardia. There's going to be a murmur, like I said. May develop CHF. There's going to be poor weight gain, diaphoresis, periorbital edema. They're going to have frequent respiratory infections like RSV. And these include PDA, ASD, and VSD, which we're all going to go over. This is just kind of giving you an overview of all of them. Decreased pulmonary blood flow. You're going to have cyanosis. You're going to have hypercapnic episodes. There's going to be poor weight gain as well, polycythemia, so they're at risk of actually a stroke. This is going to be tetralogy, flow, and transposition of the great arteries. Again, we're going to go over those. If you've got obstructed systemic blood flow in the heart, you're going to have diminished pulses, you're going to have poor color, delayed cap refill, decreased urine output, you're going to have CHF with pulmonary edema, and this is basically coarctation of the aorta, which again we're going to go over. If you have mixed defects, this is transposition of the great arteries. You're going to have cyanosis, poor weight gain, pulmonary congestion, and you may have CHF. Additional symptoms of any cardiac issues would be exercise intolerance, and in infants this would include feeding intolerance. So that means that they can't take their whole 2 ounces of their bottle, and they may become sweaty and tired, and they just cannot feed properly. In the older children and toddlers, they may have chest pain, they may have arrhythmias, or they may have syncope. Diagnostic tests that are used throughout it, and I talk about them in each defect, so you don't have to know these quite in depth as now or right now, but chest x-ray, echocardiogram, electrocardiogram, exercise testing, and a cardiac cath with angiocardiogram. An echocardiogram basically is going to confirm the diagnosis and the severity of CHF. It's going to really give you a good picture of where the anomaly is and how bad it's affecting the heart. So it's a non-invasive ultrasound of the heart. It looks at the heart size, the structure, the pattern of the movement throughout the blood throughout the heart, hemodynamics, blood flow, and any blood flow disturbances that exist. Cardiac cath with angiocardiogram is invasive. It's where this radiopaque catheter passes through the large vein or the artery into the heart, which is usually the right fem. And it's threaded to the heart chambers, the coronary arteries, or both, and it's guided by fluoro. It can identify congenital heart defects, cardiac valvular disease, coronary artery disease. It can also evaluate artificial valves and rhythm disturbances. So there are a lot of nursing implications for this if they're going to cardiocath with angiocardiogram. You want them to be NPO for 6 to 8 hours prior. So obviously these infants are going to have an IV, and they're going to be getting some fluids through that IV, and it's probably going to include sugar because they're not having any intake. 6 to 8 hours is a very long time for an infant to go without eating. You're going to check for a history for allergies to iodine, seafood, or contrast dye. Honestly, probably not going to exist in these infants because they've never been exposed to these. If it's an older kid, yes, they will have been exposed to them, but if it's infants, probably not. If they do have an allergy, you may do an antihistamine like Benadryl or a steroid prior to them going off to the procedure. They will be looking for an allergic reaction during the procedure as well to that dye. They may, if they're on anticoagulant therapy, which again is not common in children, it would need to be DC'd prior to the procedure. You're going to have IV access. We talked about this already. You're going to be getting fluids, but also for sedation and emergency drugs if needed. They're going to monitor frequent vital signs and the heart rhythm. Following the procedure, you're going to do direct pressure to the catheterization site times 15 minutes, and then you're going to do a pressure dressing for 6 hours. It's important that that affected extremity remains straight for 6 to 8 hours. And when these kids come back, the first thing you're going to want to do is assess the site. You're going to want to make sure that there's no bleeding. You're going to check the temperature. You're going to check that there's cap refill. Like I said, it's usually in the right fem, so you're going to assess that leg. Well, both legs, because you're going to compare pulses in both of the legs. But so you're going to want to do pedal pulses. You're going to want to do cap refill. You're going to want to make sure that site looks okay, clean, dry, and intact. They're going to be on bed rest. Oh, and I don't know if I said it, but that leg needs to be straight for about 6 to 8 hours after surgery to make sure that nothing breaks off or anything like that. And they're going to be on bed rest for at least 6 hours. So like I said, that extremity needs to be straight for those hours. And then you're going to limit activities for 24 hours. And you're going to do strict monitoring of eyes and nose, which you do in cardiac patients anyways. And you're going to see if that that cardiac dye can cause diuresis. Sorry, I had to take a drink. So there may be more coming out of them than usual, but that's okay because of that contrast. So congestive heart failure, or CHF. This is where you have insufficient cardiac output. So your circulatory and metabolic needs are unmet. This is due to heart problems. You're going to have congenital defects, loss of contractility, or damage due to disease, which would be like cardiomyopathy or Kawasaki or something like that in children. Congestive heart failure, again, is the inability of the heart to pump an adequate amount of blood to the systemic circulation to meet the body's demands. Approximately 20% of children with congenital heart disease will develop congestive heart failure. The majority, so 90%, will occur within the first year. So if they've got a congenital heart disease, you're going to know probably within that first year if they're going to have congestive heart failure or not. Right-sided versus left-sided failure. Again, think about that picture that I put up a little bit earlier. Infants and young children tend to have both right-sided and left-sided heart failure. Clinical manifestations result in both of the sides of the heart failing. Right-sided heart failure, the right ventricle is unable to pump blood into the pulmonary artery, so therefore there is not as much blood being oxygenated by the lungs, which increases the pressure in the right atrium and systemic venous circulation. Left-sided heart failure, the left ventricle is unable to pump blood into the systemic circulation, so there's going to be increased pressure in the left atrium and the pulmonary veins. Your lungs are going to become congested with blood, which causes increased pulmonary pressure and pulmonary edema. Their lungs are going to sound like crap. Congestive heart failure signs in infants, like I said, 90% develop it within the first year. They're going to tire easily when feeding. We already talked about that. So they are not going to be putting much out either because they're not taking much in. So guess what? They're going to be losing weight. They typically sweat very easily and sweat a lot. They're irritable, and they are prone to infections. So you want to listen to those lung sounds and see if perhaps they've developed, a lung infection, or we talked about RSV earlier. Signs in older children: exercise intolerance, dyspnea. They're going to have abdominal pain. They're going to have peripheral edema, skin monitoring, and pallor. And with that peripheral edema, their extremities are going to be cool to touch. These are signs of congestive heart failure. I'm not going to read them all to you, but know that it kind of goes from less severe, so tachypnea and tachycardia, all the way down to cardiogenic shock. So the treatment goals, the initial goal is to identify and treat the cause of the congestive heart failure. And then you're slowly going to decrease the work of the heart and improve the circulation. So like I said, you want to reduce that cardiac workload. So treatment with that is rest and oxygen. And then improving the cardiac output, treatment, digoxin, positioning, so elevation. We're going to talk about digoxin later. And then you're going to want to remove that excess fluid that's in the body. So you're going to give diuretics, Lasix, aldactones, spironolactone, or Diaril, and we're going to talk about those now. There is a chart in your book on page 554 that goes over the medications if you want to look at it. You don't have to. What I cover is what you need to know and what you shouldn't know as a nurse. But if you like charts, it's there. So Lasix is the drug of choice for acute severe congestive heart failure. It encourages the excretion of sodium chloride and water. However, because it's doing this, think about that sodium-potassium channel. It's going to deplete that potassium. And this may precipitate digoxin toxicity as well. It is a rapid onset. If it's given IV, it's going to, the onset's about 5 minutes, and the peak of action is 20 to 60 minutes. Obviously, with this, you're going to monitor with all of your drugs that you're trying, with all the diuretics, you're going to monitor I's and O's very closely. And you're going to want to monitor electrolytes as well for electrolyte imbalance. Aldactone, spironolactone is a potassium-sparing diuretic, so it promotes sodium and water excretion. Onset of action is much longer than Lasix. Peak of action is 2 to 3 days. It is a combination diuretic therapy. So you're typically going to use it in combination with, usually, honestly, you're going to use it in combination with Lasix because it can be given because the Lasix is depleting your potassium, but this one is not. But you still want to monitor, again, those I's and O's and monitor those electrolytes as well. Diaril inhibits reabsorption of the sodium and promotes excretion of sodium and water, bicarb, and potassium. The peak of action is 3 to 6 hours PO. With this one, you're going to want to monitor their blood pressure because of that reabsorption of the sodium, and you're going to want to monitor I's and O's again and the electrolyte, the balance. Digoxin, we're going to talk about more in depth because there are more issues that arise with digoxin. It is the drug of choice to treat CHF in children older than 1 month. So you probably will see this more in pediatrics. The major actions, it increases the force of the contraction, it decreases the heart rate, and increases renal perfusion. So this is the #1 thing that you need to watch out for in digoxin. Anytime, well, if the order is written properly, it should say that you need to have an apical pulse documented before you give the digoxin. And I'm not talking apical pulse from your, vitals that were done 4 hours ago. No, I'm talking about you're checking that apical pulse right before you give this medicine. And you need to check it for 1 full minute. You can't count for 30 seconds and multiply by 2. It doesn't work like that when it comes to digoxin. You're going to hold if the heart rate is less than 100 for an infant or a toddler. You're going to hold it if the heart rate is less than 80 for an older child, and if it's less than 60 for an adolescent. Just so you know, changes in the heart rhythm are a normal side effect of digoxin. Probably want to teach the patient and the parents about that. We'll go over side effects in a little bit, but I did want to mention that now. And then again, just that 1 full minute is really important. And like I said, most of the time it will be ordered like this, but you want to do it right before you give it. So home instructions for digoxin, they're going to give it every 12 hours. If they miss a dose and it's more than 4 hours late, then they shouldn't give that dose. You're going to want to give it 20 to 30 minutes before meals or 2 hours after meals to help with that digestion. And if they vomit, then do not repeat the dose. So you've all heard about dig toxicity. It's important that anybody who's on it, that you monitor for these signs and symptoms, as well as teach the family about signs and symptoms of it. So they're going to have nausea, vomiting. They're not going to feel like eating anything. They're probably going to be losing weight. They're going to have diarrhea. They may see green or yellow halos. They may have bradycardia. They may develop a dysrhythmia, which is different than the one that they have had due to the digoxin. And then they're probably going to have a dizziness and headache. It is an emergency. They would need to go to the hospital if you think they are having dig toxicity and go from there. So nutritional management for patients that are on diuretics. You're going to do a low sodium diet or low salt formula. You're going to want to use corn oil, carrot oil, or microlipid additives. This is important for infants. You're going to have a concentrated formula, so there are going to be more calories per ounce. So if you have a baby, in the hospital and they need concentrated formula, it's probably not going to be stocked. You would need to get it either specially made from the formula room or have it sent up from Central Supply. But the reason that it's going to be concentrated is because, think about it, they're tiring out during their feeding. And so if you can decrease the amount of feeding time that they need to get the amount of calories that they should be getting, then hopefully they can get those calories in while they are able to feed and still not lose any weight or maintain their weight on that curve. If it's an acute state, you're going to do a fluid restriction. So you're going to do 2/3 or 3/4 of maintenance fluid rates. You're going to have a potassium-enriched diet, again, because most of these meds deplete your potassium. And then if severe dyspnea with feeding, if the infant's experiencing that, then you may put an NG tube down or do a G tube. These are examples of potassium-enriched foods that you can encourage them to eat if they're old enough. Nursing management. So you want to feed before an intervention, because like say you're putting an IV in an infant, you want to be sure the infant has been fed before you do that IV. If you do it afterwards, they're going to be tired out and they're going to need rest and they're not going to want to eat. And so now you've just lost that opportunity. So after they've fed, you want to promote rest, conserve their energy. As soon as they are hungry, you want to feed them, because again, they are not going to have as much energy. And so if they're crying for 10 minutes because they're hungry and you're not feeding them, and then you start to feed them, you may only get 5 minutes of feeding them. Again, so answer a cry as soon as possible. You want to cluster nursing care, maintain a neutral thermal environment for them. So you don't want it too hot, you don't want it too cold, because they're already going to be sweating. Position, they're going to be in a semi-Fowler's position, so about 45 degrees. You're going to do small frequent feedings, we've already discussed. That high calorie formula. You're going to burp every 1 to 2 ounces. Limit feeding times to 20 to 30 minutes because they will just tire out. You can alternate, if they do have an NG or a G tube, do an oral and tube feedings. And you want to weigh them daily. And so you want to weigh them at the same time on the same scale. They're probably going to be naked or have a diaper on them. Most of the time they're naked. So you're going to want to do it at the same time on the same scale, and the same clothing, either a diaper or without, but it should be in your nursing notes. And if you do weigh him with a diaper, you know, if it's clean, you can subtract it based on how much that diaper weighs. And then you're going to want to report a gain of more than 50 grams per day to the doctors. So you still want to foster development because these children will grow and develop into hopefully healthy, you know, toddlers and then school-age children and adolescents. And so you still want to foster their development while they are sick. Provide age-appropriate toys. If they are old enough, you want to encourage them to sit up or even stand or walk if they can, but then you're going to want to provide a rest period. So you're still going to foster that development, but you're going to pay close attention to their needs if they're tiring out, or if they just can't do it anymore. You want to do cognition and language, still develop that. So singing, talking, music, all of that. Child life can come into play there. So congenital heart defects, there's increased pulmonary blood flow, decreased pulmonary blood flow, and mixed defects and obstruction of systemic blood flow. We're going to go over these more in depth now. So defects with increased pulmonary blood flow. You're going to have left to right shunting of the blood. The blood flows from left to right due to increased pressure from the left side of the heart. The right-sided pressure is increased, leading to increased pulmonary blood flow signs, which results in signs of congestive heart failure. These again, think about that drawing, typically acyanotic. These defects include PDA, ASD, and VSD, and we're going to go over those now. So patent ductus arteriosus, or PDA, is a common defect. It's about 5 to 10% of all defects in infants. It is a connection between that pulmonary artery and the aorta that remains open. It is common in premature babies because they are born premature, and it's going to remain open even though it should have closed. So the blood is shunted from the aorta to the pulmonary artery. The degree of shunting depends on the size of that opening. And then increased pulmonary blood flow, again, they're going to have signs of congestive heart failure. With the PDA, the diagnosis, their x-ray is actually going to be normal. On the echo, they're probably going to be able to diagnose the PDA, and they're going to visualize actually the PDA, and then they're going to measure the blood flow and so see how much it's affecting everything. There's probably going to be a murmur below the left clavicle as well. So treatment is indomethacin, which is a prostaglandin inhibitor. That's given in preterm infants only. Full-term infants, they will do a closure in the cath lab before age 5 years old. So they may do a coil placed to occlude a small PDA. If it is a large PDA, they're going to do surgical ligation. And an unrepaired PDA will lead to pulmonary hypertension. But if it is repaired properly, there is an excellent prognosis for the repaired PDA. Next, we have the atrial septal defect, which is ASD. The hole can be small or large, and it's a hole between the atria. So blood is shunted from high pressure left side to the right side of the heart, which leads to increased volume on the right side. So you're going to have right atrial and ventricle hypertrophy, and you're going to have an enlarged pulmonary artery. It may be asymptomatic, again, depending on the size. If it's small, they may not have any symptoms. They may have a heart murmur, again, if it's large. If the hole is large, they're going to have signs of congestive heart failure. Chest x-ray may show cardiomegaly, again, only if it's large. And the echo is really going to help them to see how big the hole is and how much the hole is affecting the heart. So treatment, if it is a large ASD, you're going to treat the congestive heart failure. There is possible spontaneous closure by 2 years of age. So if it hasn't closed by 2 years of age, around preschool, they're going to go ahead and do surgery. So they're going to have a median sternotomy, or they may do a non-surgical repair, probably again depending on the size, which would put an occluding device placed during cardiac cath. Complications of doing the repair is arrhythmias, and these infants and toddlers may be at risk for stroke long term as well. The next one is ventricle septal defect, VSD. This is the most common congenital heart defect. It's about 15 to 20% of cases of pediatric heart defects. It's a hole between the ventricles which shunts blood back to the right side so that blood is recirculated to the pulmonary artery. So you're going to have increased pulmonary blood flow, which results in the left side of the heart being engorged and pulmonary vein congestion. And the degree of the shunting depends on the size of the defect and the amount of the pulmonary resistance. So again, these can be small or large. If it's small, they may be asymptomatic and it may actually not be diagnosed until later in life. If you have a moderate to large VSD, you're going to have congestive heart failure. They're going to have a murmur. The X-ray, again, may show cardiomegaly if it's large. And the echo is going to show the size and location of the defect and, again, what effect it's having on the heart. So treatment, if it's small, there is no treatment. 3/4 of these will close on their own spontaneously, typically within the first 6 months of life. If there's a large VSD, you're going to treat the CHF and they're going to have surgery around 3 to 12 months. There is a good prognosis. However, some of these children may be on meds long term and they may need a pacemaker. It just depends on how much damage has been done. So defects with decreased pulmonary blood flow, this is going to be tetralogy of Fallot and transposition of the great arteries. You're going to have right to left shunting of unoxygenated blood. So there's going to be a mix of oxygenated and unoxygenated blood in systemic circulation, which is going to result in hypoxia and cyanosis. The body compensates in response to this hypoxia by increasing the red blood cell production. You're going to have polycythemia, which leads to increased blood viscosity. So the hematocrit is going to be greater than 65%, which puts these children at a risk of stroke. They're going to have increased afterload and ventricular workload, decreased clotting factors with platelets, and so they're at a risk for bleeding problems. All right, so tetralogy of Fallot. This is actually 4 defects in one. So they're going to have pulmonary stenosis, they're going to have right ventricular hypertrophy, they're going to have an overriding aorta, and they're going to have a VSD. So the pulmonary artery is narrowed, so the right ventricle must pump harder. So then you're going to get right ventricle hypertrophy. And then due to the VSD, there's going to be equal pressure in the ventricles. And so blood is unable to get to the lungs, which equals cyanosis. There is something called pink tet, which is there's only a small narrowing in the lungs so that actually enough oxygenated blood gets out to the system. So they do appear pink and healthy, but they're not. So tetralogy of Fallot continued. Signs and symptoms will depend on the size of the pulmonary stenosis. Older infants and children will have tachypnea and cyanosis. There's going to be a systolic murmur at baseline. These children are going to have something known as TET spells, which are hypercyanotic spells that can occur during periods of increased activity. So if they go home and they have tetralogy of Fallot, You're going to have to teach them and the parents that when they're an infant, they're going to need to kneel and go to a knee chest position to decrease the systemic venous return. If it is severe and some of these kids might not leave the hospital, then you're going to want to monitor the labs for metabolic alkalosis. Again, it depends on the severity and the size of the pulmonary stenosis on how severe and how aggressive the treatment is going to be. Some of them can go home and, like I said, become an infant before they might need surgery, or some of them may never leave the NICU until they get surgery, and they'll have these TET spells in the NICU, every time their diaper's changed or every time they get hungry. So again, it just depends on the severity of it. So diagnosis, a chest x-ray might have right-sided hypertrophy or a prominent aorta if it's a big one. Again, the echo is going to let you visualize what's going on in the heart. Treatment, you're going to want to manage those TET spells. So with positioning, with oxygen, meds to increase systemic vascular resistance. This is the Blalock-Towsing shunt is a palliative shunt that's done that is temporary to help to get a fixed amount of blood flow. And then so that is palliative to get them to 3 to 12 months old when they can do surgery. And again, surgery may be staged over several years. And unfortunately, not all children are cured by surgery. So like I said, surgery may be staged over several years. So again, if they're a toddler and are in the middle of their surgeries and are going home, then you're still going to want to educate them on those TET spells and that knee to chest positioning. Transposition of the great arteries, or TGA, is life-threatening. It's very severe. It can also be viewed as a defect that causes increased blood flow, but it is cyanotic. So this is when the aorta and the pulmonary artery are reversed, and you've got a patent foramen ovale. So unoxygenated blood flows from the right atrium to the right ventricle to the aorta, and oxygenated blood flows from the lungs to the left atrium to the left ventricle to the pulmonary artery and the lungs. So basically, there is no oxygenated blood going out to the body. Think about it. These arteries are transposed, so they are where they should not be. So the blood is not flowing properly, and so it's not getting oxygenated and going to the lungs like it should, and so your body is not getting any oxygenated blood. So the only way to survive this is if they have an intra-atrial connection, so like ASD, PFO, PDA, so that the blood can mix and some oxygenated blood will get to the body. And basically the child's survival depends on these things. And so cyanosis is seen soon after birth, and it does not improve with oxygen. So think about, right after that baby's born, you're doing you're doing your APGAR scores, and they're cyanotic and they're not getting any better, and so you're going to apply oxygen and they're still not getting any better, and so now you're really worried. And honestly, the signs and symptoms of congestive heart failure can be immediate. So they may even have come out not only being cyanotic, but also having all the signs and symptoms of congestive heart failure. So diagnosis is clinical presentation. Again, those APGAR scores, not responding to oxygen, congestive heart failure signs and symptoms. You're gonna want to do an echo or a cardiac cath if you have time. So the main treatment and the main thing that you want to do, and this is going to be stat. So again, in the first 5 to 10 minutes of this child's life, you're going to want to give prostaglandin. And again, it's going to be stat, and the prostaglandin is going to help to keep that PDA open so that hopefully they are getting some oxygenated blood. They can do an atrial septostomy. Sorry, I can't say that word apparently. Which will make an ASD to allow mixing of the blood until the surgery can be performed. So again, that's a palliative surgery. And then surgery, like I said, is immediate, and it's going to be done. They're actually going to go in and switch those arteries, and it's done about a week or two after birth. That prostaglandin is life-saving though, and is going to keep that PDA open so that they can make it, hopefully, to surgery. Okay, so defects obstructing systemic blood flow. This, you're going to have left-sided obstruction that causes increased afterload to the left ventricle, and you're going to have coarctation of the aorta, or COA, which is a narrowing of the aorta, and increased resistance to blood flow out of the left ventricle, which equals left ventricle hypertrophy. Signs and symptoms include you're going to have CHF in infants. The older children may actually be asymptomatic. However, you're probably going to see marked hypertension in upper extremities when compared to the lower extremities. So that also means you're going to see stronger pulses in the upper extremities and the lower extremities. So it's important, again, this is where nursing assessment comes into play, that you're palpating all 4 pulses and documenting how strong they are. And in this case, if you notice a difference in the pulses, you may want to take a blood pressure in all 4 extremities. So this, you can diagnose it with a chest x-ray. You may see cardiomegaly again. An echo is going to tell you the size of the aorta and the function of the aortic valve and of the left ventricle. These children are going to need lifelong follow-up. Treatment is basically surgical resection performed, or you're going to have a balloon. And the surgical resection is much preferred over the balloon. And so post-operatively, you're going to want to control that hypertension, and long-term complications, like I said, about lifelong follow-up needed. This is, you're going to want to monitor for hypertension. They may be on antihypertensives, and then they are at risk for recoarctation. Okay, so this is just talking about cardiac surgery, any cardiac surgery involving children. So preoperatively, you're going to want to assess growth. So you're going to want to assess their weight. We've talked about how important I's and O's are. Assess their weight, their length, their head circumference. Are they growing properly? Are they not growing properly? You're going to assess for signs of CHF. Do they have fluid in their lungs, etc. You're going to teach surgical and post-operative expectations to the parent, and if the child's old enough, obviously you want to do age appropriate. You're going to provide support for, it is an uncertain outcome. You know, these children are having cardiac surgery, and like I mentioned in tetralogy flow, even with surgical repair, it may not be curative. So the parental role is huge. They're going to want to promote good nutrition. So they're going to want to, that good nutrition is hopefully going to help the baby grow as much as they can. You know, these children are not going to be in the 80 or 90 percentile range for their age and weight, or sorry, for their age. They may be in like the 30s or 40s, but if that's where they are and they're staying on that trend, then that's what's important, and the parents are doing a good job. Also, preventing infections is important, because think about how much more stress those infections are going to put on these little infants or toddlers with a heart illness already. And then they can ensure that immunizations are up to date prior to surgery. Cardiac surgery, again, you're going to want to teach the child and the family using age-appropriate toys. Talk about the experience, what they can expect from it, and then post-operative care, they are definitely going to be in the PICU and nowhere else. And they may actually, VCU's recently gotten a heart doctor, but before that, they would go to a hospital that had a heart doctor because we didn't. So you definitely want a pediatric cardiologist operating on you, or pediatric cardiology surgeon operating on you. So post-operative care, nursing is important. You're going to provide pain control. You're obviously going to monitor vital signs very closely. They're going to be in the PICU. They're going to be on those monitors. They're going to be monitoring their heart rate and blood pressure very closely. You want to prevent any complications from surgery that you can. So you're going to want to prevent infection, monitor their temperature, assess that surgical site, make sure there's no blood or drainage coming from it. If they do have an arrhythmia, you're going to do cardiac monitoring. You're going to auscultate the apical pulse for the irregular heart rate or bradycardia. And obviously, if it's present, you're going to notify the doctor immediately. You're also going to want to look out for signs and symptoms of impaired tissue perfusion. So pulse oximetry, cap refill, extremity warmth, pedal pulses, level of consciousness, urine output. You're going to want to monitor fluids like you have the whole time. So careful eyes and O's. And then carefully increase the activity level as tolerated. You don't want to go too fast on these children. Again, post-operative care, you want to promote respiratory function because complications are common after surgery, like pneumonia or pleural effusion. So you want to do incentive spirometry if they're old enough, or chest physiotherapy. So if they're not old enough, like 3 and 4-year-olds, you're going to want to do bubbles or pinwheels, something to get that chest and those lungs being active. This is also an extremely stressful time with for the parents, obviously. Their kid has just had open heart surgery, and so you want to listen to their concerns. You want to answer their questions, provide them with breaks if they need it. Simple things, bring them water, a blanket, a pillow, whatever, to, maybe give them a pinwheel when their child's doing the pinwheel. Just little things like that can make a huge difference. So they are actually, even though it is obviously major cardiac surgery, they are actually discharged within a few days. And so it's important to educate both the adult or the parents and the child if age appropriate. So avoid activities where the child could fall and strenuous activities for 6 weeks until that sternal incision is completely healed. Also, if they're younger, you don't want to pick them up under the arms because you can break open that sternal incision. So avoid that. Avoid large crowds for at least a week to help to prevent any infections. The child may return to school about 3 weeks after discharge, depending on how he or she feels. The parents need to report signs and symptoms of that wound infection. So again, if they see drainage or blood around the wound, they need to call the clinic or go to the hospital. And obviously we don't want them soaking that incision. Monitor for fever, flu-like symptoms, monitor for increased respiratory rate or distress because they are at risk for pneumonia or a pleural effusion. Monitor for appetite change because they may not be able to feed as well, or irritability immediately. And so again, all of these they're going to want to monitor very closely and either let the clinic know or go to the hospital. So this is post. Before, it's important they get their immunizations. However, post-operatively, you're going to delay those immunizations and dental work for at least 2 months so that you're not putting extra stress on that body. Antibiotics will be needed before dental and surgical procedures for the rest of their life. And then during the first 2 months following surgery, they're going to want to report any unexplained fever or illness. All right, we're getting towards the end, guys, I promise. All right, so there are 2 types of acquired heart disease. So everything we've talked about up till now, you're born with, right? These are acquired in childhood. And so you've got rheumatic fever and ineffective endocarditis. Rheumatic fever, again, an acquired heart disease. The incidence is actually pretty low in the United States because we tend to treat strep early, which is the cause of it. But it is rampant in third world countries and, other areas that maybe don't have access to medical care because they aren't treating that strep early. So that's just my little tidbit. All right, so systemic inflammatory autoimmune disease, it affects the connective tissue of the heart. So there's going to be long-term damage to those heart valves. It's going to affect their joints, their skin, their subacute tissue, and their central nervous system. So it usually develops about 1 to 3 weeks after a group A beta hemolytic strep infection. It can manifest as a URI or strep, and it's most common in patients 5 to 15 years of age. And if it's untreated or is a partially treated infection, they can also still continue to develop this. So again, that's when your education comes into play about educating parents on giving that entire antibiotic to make sure that it all goes away. Because if you don't, then you can lead to serious complications. And so anti-streptococcal antibodies are produced, and so it forms an immune complexes. It reacts with the cardiac tissue, and it produces an inflammatory response. So again, the myocardium and the valves, and it can and does result in permanent mitral and aortic valve damage. Manifestations, you're going to have carditis, so you're going to have inflammation of all of the areas of the heart, but the mitral valves primarily. So they're going to develop a new heart murmur. These people will not have, or these children will not have had a heart murmur, and now they're going to have a heart murmur because of the valves being inflamed and affected. They're also going to have polyarthritis, so they're going to have tender, painful joints, elbows, knees, ankles, wrists. They're going to have Sydenham chorea, which is honestly just a medical fancy term for kind of a twitch. They're going to have involuntary movements of their legs, arms, and face. They're going to have subacute nodules. They're going to be small, non-tender lumps, and they're going to be located over the joints. Major manifestations, they're going to have this rash called erythema marginatum. Again, I'm killing these words today. So they're pink macules that blanch in the center, and it starts on flat raised, it starts out as flat or slightly raised macules, and it's going to start in the trunk or proximal extremities. Interestingly enough, this rash is never going to be on the face or the hands. It is going to spread peripherally from the trunk, but again, it's not going to develop on the face or the hands. So minor manifestations, they might have a fever, arthralgia, they're going to have an elevated ESR or a positive CRP. They're going to have EKG changes again because of the effect on the valves. They're going to have prolonged PR intervals. So a diagnosis is based on clinical signs. The Jones criteria is listed on 552, but it's basically all of the manifestations that we have just gone over. And so the Jones criteria is that you either have 2 major manifestations or 1 major and 2 minor manifestations plus evidence of a recent streptococcal infection. So they're going to draw an ASO on you. And so what that ASO tells you is that they have had a recent strep infection. Medical management, they're going to, most recover fully. They're going to be on, put on penicillin, sulfa, or erythromycin for that infection. They're going to be on Tylenol for the fever. They're going to be on aspirin for carditis and joint inflammation and also the fever. They may even be on steroids for the inflammation, and rest is important for them. So prevention, again, we talked about it. You want to be sure, if you know children that do have a positive strep culture, that they get 10 days antibiotics and they take the full course and the full dose, and the dose is appropriate. If you unfortunately can't prevent it, you're going to auscultate that heart and you're going to note any unusual sounds. You're going to support their joints, make sure they're in a comfortable position. So you may alternate heat and cold, offer massage, and then quiet activities. They tend to not like it, but usually they need to be, they're actually usually placed on bed rest. And so you're going to want to offer board games or movies or reading, and something, again, that is age appropriate. Child Life can help with that. You also want to test family members for strep. People don't think about that, but the family members may be carriers of strep or may have strep, active strep, and they're just asymptomatic. So you might also want to get the whole family tested and get them treated so that they don't develop rheumatic fever. Rheumatic fever isn't as common in adults, but my aunt actually got it. My family has all the weird diseases, but my aunt actually got it, I think, in her 40s. And she recovered from it, but she did have some damage to her heart valve, so she is on medications now due to that. So discharge teaching, they're going to be on strep prophylaxis throughout adulthood, because if they are exposed to strep, they are more likely to get rheumatic fever again, and so we're going to try and prevent them from getting strep. So again, it's going to be throughout adulthood. So they're either going to get an IM dose of bicillin every 28 days, or they're going to get an oral dose of penicillin 3 times a day. So you kind of pick your poison on that one. You need to teach the importance of this prophylaxis, and because again, if they get rheumatic fever again, their valves are going to be further damaged, and they may then end up with congestive heart failure and stuff like that. So this prophylaxis is really important. All right, ineffective endocarditis is inflammation that results in an infection of the endocardium, the endothelium, or the heart valves. This is life-threatening, but it is uncommon infection unless they have so it's rare unless they have an existing known heart illness. So, like we've talked about, congenital heart disease, rheumatic heart disease, if they've got an artificial valve, if they have a central venous catheter, they've had past heart surgeries, all of that puts them at risk for this. So it is, again, uncommon, but it's common. It's more common in that population. And so bacteria causes it, staph, strep, and enterococci, or fungus. Diagnosis, you're going to want to do a blood culture because that's going to tell you what organism is causing this infection. And so you're going to obviously want to be able to treat it properly with the proper antibiotics. The echo can ID vegetation, so if there's anything that is dead on the heart or infected lesions in the heart. It can also, you can see valve damage, you can see the cardiac function, and you can actually see the site that it's infected. You're probably going to do a urine culture, a CFS culture, and then there's other blood works in there that would be positive. Symptoms may be mild and develop slowly, or may be severe and develop quickly. It just depends on the person and the severity of it. So the heart murmur, again, if they've had all these congenital, or if they've had congenital heart disease or heart disease in the past, they probably already have a heart murmur. So if they don't, and now they have a heart murmur, that is a symptom. However, if their heart murmur has changed, so it's important to have good documentation on that heart murmur. But if their heart murmur has changed, then that is a sign of endocarditis. They're probably going to have a low-grade fever. Typically, they're going to have afternoon elevations. They're going to have sweating, fatigue, joint and muscle aches, headache, anemia. They're also going to have signs and symptoms of CHF, so they're going to have dyspnea. They're going to have weight loss. They're going to have blood in their urine. They're going to have that petechiae rash, and they may even have conjunctival hemorrhage. They are going to be on IV antibiotics for 2 to 8 weeks, and honestly, it's a minimum of 4 to 6 weeks. And so antibiotics, again, we've talked about nursing implications with antibiotics, but it's important to give them on the same time, on time, scheduled. They're probably going to have surgical interventions to remove that vegetation and maybe replace the heart valve if it's dead. You're going to treat that CHF with bed rest and medications like DIG or Lasix. You're going to want to prevent for at-risk children, so like the ones that we talked about earlier. You're going to want to do prophylactic antibiotics before and after any surgical interventions or procedures on these areas, because those are the ones that lead to the most common bacteria that cause this endocarditis. Also, you're going to want to do good oral hygiene, which is going to reduce periodontal infection. So you're going to want to give antibiotics before they go to the dentist for those at-risk children. They probably are going to have long-term venous access, so a central line. So you're going to want to, do teaching on that for home teaching, or if they have somebody come out, that you want to certainly teach on monitoring for signs and symptoms of infection on that. Discourage body piercing and tattoos. This is going to increase their risk of infection. And think about it, it's not just your ear that you might get pierced. And so if you're getting somewhere else pierced, it can even put you at more of a risk for endocarditis. Or if the person before you got somewhere else pierced and they didn't properly clean it. So just think about that. Nursing management, if they have that central line, obviously you want to do that aseptic technique. Watch out for side effects of antibiotics. You're going to want to promote rest, do quiet, appropriate developmental activities. You're going to want to monitor their temperature, or give Tylenol if needed. Family teaching, again, is going to come into play because they're usually going to go home on antibiotics, and so you're going to have to educate them on that. And then they're going to go home with a central line as well, so you're going to have to educate them on that. And then, provide coping skills, make sure that they're participating in the care. You can provide quiet activities for the family and the child, so board games or something like that. Okay, so that is it. I know this was an extremely long lecture, and it can be overwhelming for this whole lecture can be overwhelming, and I don't want it to be overwhelming for you guys. I will tell you I'm not going to test you on knowing if it's going from the right to the left and what's being affected, but it's good to know a baseline of the heart and know, how it works, and know the nursing management we talked about and the diagnostic testing and the medications, and use your test plan to help you guide you through this because it is a long lecture. But I am here if you need any questions or need further guidance.